Okay, inborn errors in metabolism. This is going to be the genetics of amino acidemias, organic acidureas, urea cycle disorders, glycogen, and sugar metabolism. This is to kind of dovetail again with the biochemistry. We are going to go over clinical presentations of these disorders and not go into as much detail on the peculiarities of the enzymes and things like that, although we are going to discuss that. So the clinical presentation of a metabolic disorder is and the reason I say nonspecific, the baby's tired, lethargic, decreased feeding, maybe vomiting. Sometimes these symptoms are progressive to seizure or coma. But these symptoms can be seen in a lot of different things, a lot of different disorders in a baby. So a newborn crash is defined as usually it's a full-term infant that looks healthy at birth. And the reason for that is the placenta is filtering all these byproducts from the baby. But then you cut the cord and you no longer have the placenta to filter these things, and the baby starts getting into trouble. Non-specific, again, oftentimes it starts slowly. Poor feeding, vomiting, lethargy, progressive. Sometimes there's an abnormal odor to the urine. And we're going to talk about this more, but if there's an unusual odor to the baby or to the urine, or you're reading an exam question and they're telling you what the urine smells like, think about it. Might be a clue. So differential diagnosis for a newborn crash. And again, sepsis. I should have made this like 10 times bigger. The first thing, the second thing, the 10th thing that I think about, or anyone should think about, in a baby who looked healthy and now looks horrible, is that they have an infection. And it should always be the first thing. There also could be adrenal insufficiency. There could be a congenital heart defect or an arrhythmia or asphyxia. The asphyxia, the baby, even if the APGARs, the most inaccurate measurement that we do in medicine, were normal at birth, maybe right before birth, the baby had a hypoxic incident and it looked fine, but then cells started dying and the baby starts looking horrible. But if it's not one of those things, it could be an amino acid abnormality, a urea cycle abnormality, organic aciduria, or mitochondrial. We're not going to talk about mitochondrial today, except for a little bit in the flow charts, but I'm not going to ask you about it. This is a flow chart. There are no perfect flow charts, but I'm just going to kind of go through this a little bit to the thought process. So you have this baby, lethargic, coma, seizures, vomiting, maybe an abnormal odor. Is the baby acidotic? Is the HCO3 under 16? And if it's acidotic, and we're going to go over this in more detail, where is this acid coming from? Is it coming from lactic acid, as is in the case of some mitochondrial disorders that stands for pyruvate carboxylase or dehydrogenase? We will go over this at another time. Or secondary, such as tyrosinemia, which is an amino acid disorder, galactosemia, which is a sugar metabolism, coarctation of the aorta. Some of the highest lactic acids I've ever seen are because of a heart defect. Or is it coming from organic acids? So is it coming from lactic acid or organic acids, such as some of the amino acids in organic acid disorders? If the baby's not acidotic but looks kind of pokey here, what is the ammonia? If it's over 200 and usually higher than that, it could be a urea cycle defect, which we'll go over. But everything could be normal, and we could still have like phenylketonuria or PKU. So all these things could be normal, and we could still have a metabolic disorder. So metabolic acidosis, decreased blood pH caused by an accumulation of hydrogen, decreased bicarbonate, and decreased PCO2 because of hyperventilation. The question to ask yourself is the acidosis the result of an abnormal loss of bicarbonate, in the case of diarrhea, or the accumulation of an acid? And we use the Henderson-Hasselbalch equation to measure the anion gap. So it's plasma sodium minus chloride plus HCO3, and normally it should be between 10 and 15. And when it's elevated, we start thinking about organic anions. So a metabolic disorder results from the accumulation of organic anions, and clinically, again, usually there's a mild acidosis even when the child doesn't look that sick. This is just a different diagram about metabolic acidosis. So if you have metabolic acidosis and you have a normal anion gap, it's probably you're acidotic because you're losing bicarb. And this can occur in diarrhea or renal-tubular acidosis, or RTA. When it's expanded, it could be an accumulation of fixed acids, and that's when you're thinking about an organic acidopathy, ketoacidosis in the case of diabetes, or lactic acidosis in the case of the mitochondrial disorders. Now, it also depends on the age of the child. If it's a 5-year-old with an expanded anion gap because of an accumulation of fixed acid, this is going to be your answer. This might be diabetes. However, a newborn with acidosis with an expanded anion gap, organic acidopathies or inborn errors in metabolism are far more common, as rare as they are, than newborn diabetes. So it also depends on the age of the individual that you're looking at. So organic acidurias, there are many defects that result in this group of organic acidurias. Clinical features usually include decompensation the first 2 weeks of life, and it can present later with a partial block. Clinical features include acidosis, elevation of anion gap, elevated lactic acid, and hypoglycemia. Well, also, as I try to differentiate one of these from the other, how old was the baby? If it's in the first 2 weeks of life, you're going to be thinking of this. Examples of organic acidurias include methylmalonic, isovaleric, propionic, maple syrup urine disease, and glutaric acidemia. Clinical features, and again, these are all super rare disorders. I do not expect you to differentiate between one or the other, and quite frankly, only metabolic geneticists are expected to be able to differentiate between one of these or the other. But the features of organic acidurias include ketoacidosis. Sometimes glycine is kind of a soft sign on the amino acids that there's an organic acidemia, hypoglycemia, a little bit of neutropenia or bone marrow suppression, and a mild elevation of ammonia. And this is more because the liver is not too happy. So the first disorder I want to talk about, and again, I'm not going to go into all the details of these enzymes except for to talk about them, but to talk about the clinical presentation. So usually they present after the age of 1, so a little bit later than most organic acidemias. And usually they present after a incurrent viral illness. They have a virus and that increases their metabolic rate and have issues. But even prior to that, they usually have a big head, megalencephaly. And it's the head is large, but there's not a lot of brain tissue, so it's called microcephalic macrocephaly. So there's lots of fluid there, but not as much brain tissue. Often they have relatively normal development in the first, prior to the first major episode. And here's a little girl before and after a major episode. But sometimes they do have signs including profuse sweating, unexplained fevers. This is inherited in autosomal recessive fashion. Any enzyme that if it's an enzyme that breaks something down, it's usually recessive or possibly X-linked. But a lot of these enzymes, you only need about 50 or maybe even 20% of enzyme activity to work. So again, just a little clue when we're trying to figure out what the inheritance is. It's this particular disorder, glutaric, is more common in the Pennsylvania Amish population. The reason I give you these little hints is if you're reading an exam question, they might give you some very strange, superfluous information, and this might help you get to the right answer. I would not ask that, though. Diagnosis of glutaric, there's elevation of glutaric acid on urine organic acids, and the MRI, and this has to do with the clinical features, can show subdural hematomas. The subdural hematoma is because of tearing of the blood vessels, but it can also be mistaken in child abuse. We actually test, and in most states in the U.S., we test through something called mass spec for all metabolic disorders. So, and it's relatively accurate because it's not done in every state. It's not on the list of things that they would ask you for the boards, but it is important information to understand. When I see a child who looks really sick and has a subdural hematoma, this would be on my differential. I would have hoped that it would have been picked up on the newborn screen. However, it's always possible that it wasn't. So I usually recommend that they send serum amino acids in, primarily urine organic acids. So I recommend those two studies. If a child has a subdural hematoma with a depressed skull fracture and retinal hemorrhages, it's probably abuse. But I usually send the testing anyway, just to rule out any kind of metabolic disorder. The next thing I want to talk about is maple syrup urine disease. And in this situation, the baby deteriorates in the first couple weeks of life. So again, Glataric presents a little bit later. The ammonia could be normal to mildly elevated. The lactic acid's usually normal. The glucose is usually normal. The serum amino acids show a certain pattern of elevated amino acids, including leucine, isoleucine, and valine, and these are known as the branched chain amino acids. And the maples, there's kind of a sweet or maple syrup odor to the urine or earwax. It's an enzyme, so it's inherited in autosomal recessive. It's very uncommon, about 1 in 100,000 to 1 in 300,000. So why the heck am I telling you about this? I don't. But 1 in 200 in Mennonites, and it's also more common in Ashkenazi Jewish descent and French Canadian. So it's caused by a non-functional enzyme in the branched chain complex. So that makes sense for the decarboxylation of the keto acids leucine, isoleucine, and valine. Serum amino acids note elevation of leucine, isoleucine, and valine, and the elevation of isoleucine results in the sweet smell to the urine. The elevation of leucine is transported to the brain, the elevated leucine, and the leucine is converted to glutamate and glutamine, and this damages neurons. So the sweet smell to the urine is because of isoleucine, but the real problem is this leucine that results in neurologic damage. The next group of disorders I want to talk about are amino acidemias. And amino acids are the building block proteins. There's essential amino acids, and the rest of them are made from each other. So I know this isn't the clearest of slides, but it's the best one I could find. And various enzymes are involved in converting one to the other. But the most important one that you need to know is phenylketonuria, or PKU. This was actually the first thing that was ever tested for in the newborn screen, and they started in the early 60s. Of the newborn screening, and every single baby in the U.S. is tested for PKU, so this probably is fair game. What they used to do, what we do now is we actually look at the phenylalanine on a mass spec. What they used to do is, that's the reason that the PKU cards are on filter paper. They would cut out a little piece of filter paper and put it on agarose gel that was deficient in phenylalanine. But if the bacteria grew, then that meant that phenylalanine was really high, and they could actually measure the amount of phenylalanine by how large the circle was. But the real problem with phenylketonuria is phenylalanine cannot be converted to tyrosine through this enzyme phenylalanine hydroxylase. And so when it can't go this way, it has to go this way. And we get our amino acids from our amino acid pool that we get from eating proteins. So it gets shunted to phenylpyruvate, which is turned into a bunch of acids, phenylactate, phenylacetate, phenylethylamine, and glutamine. And these are all toxic to the brain. If untreated, infants with PKU can lose 50 IQ points in the first year of life because of this chronic damage of the brain by the elevated phenylalanine phenylpyruvates. Symptoms of untreated PKU include a mousy odor and a progressive microcephaly. Again, we're losing brain cells. Management of PKU is a low protein diet with limited phenylalanine. Kuvan is a medication which can improve enzyme function of patients with a deficient but some enzyme activity. And diet soda, such as Diet Coke, here it says phenylketonuria contain phenylalanine. Aspartame is very high in phenylalanine, so the worst thing you could ever do for somebody that has PKU is give them a diet soda that's pretty much like poison to them. Homocystinuria is the inability to convert the amino acid homocysteine to cysteine because of the deficiency of the enzyme cystathionine synthetase. And so here we have homocysteine should go to cysteine, but this enzyme's not working, so it's shunted to homocysteine with the INE that's excreted into the urine as homocystinuria. Elevated homocysteine can result in a prothrombic state, which increases the risk of blood clots. Unlike most metabolic disorders, I mean, we did have some macrocephaly with glutaric, but homocystinuria has specific dysmorphic features. They have what we call marfanoid habitus, long fingers, joint hypermobility, tall stature, sometimes a pectus deformity. But unlike marfans, they can have cognitive delays. And the other major feature is downward dislocation of the lens. In marfans, it goes up, and in homocystinuria, it goes down. Tyrosinemia. Elevated tyrosine results in renal tubular acidosis and liver failure. Serum amino acids note elevation of both tyrosine and methionine. And presentation can vary, but includes failure to thrive and vomiting. And the urine can have a rotten cabbage smell. And again, it's an enzyme. It's autosomal recessive. So here's just a little thing about odors and metabolic disease. Isovaleric smells like sweaty feet. Maple syrup urine disease, a sweet smell. Phenylketonuria, a mousy smell. And tyrosinemia, rotten cabbage. Next, I want to move to the urea cycle. And the purpose of the urea cycle is to break down nitrogen and excrete it in a water-soluble form, which is urea. There are a number of enzymes involved in the process. In the urea cycle, we have our ammonia, and what we're trying to do is excrete it in a water-soluble method, which is urea. So our ammonia we get from breaking down proteins, so we combine that with a CO2, and that becomes carbonyl phosphate. The carbonyl phosphate attaches to ornithine with the enzyme ornithine transcarbamylase and goes to citrulline. When this enzyme doesn't work, our citrulline is low, which we actually see in amino acids, and our ornithine is very high. The next step is citrulline adds an aspartate through an enzyme and becomes original succinate. When this doesn't work, the citrulline is very, very high, and this is known as citrullinemia. Original succinate is then converted to arginine, which is actually the amino acid arginine is created during the urea cycle. And when that doesn't work, our arginine is actually pretty low, and it's caused by the enzyme original succinate lyase. And the final step of the urea cycle is arginine then is converted back to ornithine, releasing this water-soluble form of nitrogen in urea. And when this last step of the enzyme does not work, arginase deficiency, the arginine is very high. So in original succinate or even citrulline, the arginine be low, but in arginase, the arginine is very high because it gets to here, can't get over here. So symptoms of a urea cycle defect, because of the accumulation of ammonia, patients with urea cycles are alkalotic. So we were talking about a lot of these acidosis that they're acidotic. This is alkalotic, and the ammonia can reach like the thousands. And elevated ammonia can result in the patient being lethargic, very sleepy. This is true of children or adults. Elevated ammonia affects the liver. So ornithine transcarbamylase, one thing most of these urea cycles, except for arginase, which can present a little bit later, usually present in the first day or two of life. So while the organic and the aminoacidemias may present slower, maybe in the first couple weeks, ornithine transcarbamylase usually presents in the first 1 to 2 days of life with the baby. It looks fine when it's first born, and then the feeding starts not being as good, and they become lethargic. The OTC gene is located on the X chromosome, and girls have 2 X chromosomes and boys have 1. So I don't even like to use the word X-linked recessive because females can have symptoms depending on X inactivation of the liver. So if they're lucky and their liver all has their good X on, they're making plenty of this enzyme, they'll be fine. And if they're not so lucky and their liver is, has the inactive one on, then they could have issues. But some of the symptoms include low citrulline, as I showed you back on that other slide from the urea cycle. So this is the first step, OTC. So the citrulline is low, as well as the arginine. Males usually present in the first few days of life, and females present a little bit later, and sometimes it's precipitated by a high protein meal. Sometimes they have concerns about people going on a ketogenic diet, and if they were a mild carrier of this, they might present with symptoms. Citrullinemia, autosomal recessive, males and females are equally affected. This is that second step. Babies present with hyperammonemia in the first week of life, usually the first couple days. Amino acids usually show a very high level of citrulline. And management is arginine supplementation because the arginine is usually low. All urea cycles, low protein diet, and monitor for signs of hyperammonemia. Original succinate lineage, the third one, again recessive, presents a little bit later than OTC and citrullinemia. Elevated ammonia, arginine is deficient. It's usually the most deficient of any of these. And management, again, arginine supplementation, low protein diet, and monitor for signs of hyperammonemia. Arginase, a recessive, again, a little bit later, and actually can present with increased muscle tone or symptoms that look very much like cerebral palsy, and it's because of the chronic damage to the brain. Ammonia is elevated, arginine is elevated, unlike all the other ones where it's low. So if the arginine is elevated, it's a sign of arginase deficiency. And symptoms, like more severe symptoms, can occur with a incurrent viral illness. And the treatment is a low protein diet. If we're not very good at getting rid of these proteins, let's limit the amount of protein in the diet. So again, nobody with any type of urea cycle should ever be on the ketogenic diet, because that's a high protein diet. So galactosemia is a sugar metabolism problem, and galactose is not really usable by our body, so we have to convert it to glucose, and we do it through a series of 3 enzymes that go from galactose to glucose: GALC, GALT, and GAL. GALT is the most common, which stands for galactose 1P uridyl transferase. These are less common, but when we cannot convert galactose to glucose, and all 3 of these result in what we would consider galactosemia, galactose is then turned to something called galacatrol. And galacatrol is toxic to the liver, and these unmetabolized sugars are seen in the urine as reducing substances. The classic presentation of galactosemia include jaundice, a big liver, vomiting, feeding intolerance, and E. coli sepsis, as well as cataracts. I bolded the E. coli sepsis because this is actually something that can kill these babies very quickly. Galactose is kind of food for the gods for E. coli. E. coli flourishes in the presence of galactose. So a baby that has tons of galactose sitting around can become sick very, very quickly. They can become hepatotoxic or die from sepsis within days. So again, this is something performed on the newborn screen, and this is something that we need to call a family immediately when we find this out, because the treatment, if you can't break down galactose. Lactose consists of glucose plus galactose, so a lactose-free diet. So soy formula is given. Now, one of our biggest problems is that breast milk has lactose, and we encourage, I'm a card-carrying member of the American Academy of Pediatrics. We encourage every mom to breastfeed. It is the healthiest thing, except for if we think the kid might have galactosemia. And again, it is tested for in most states. But, you know, you would never be asked what is on a newborn screen because every state's a little different. But you could be asked, a baby is diagnosed, there's concern on the newborn screen for galactosemia, what would you do? And what you would do is switch the baby from breast milk to a soy formula. The next sugar metabolism disorder I want to talk about is a group of disorders known as glycogen storage disorders. And these are a group of disorders characterized by non-functional enzymes involved in either the breakdown or synthesis of glycogen. And glycogen is how we store sugars. The hallmark of this disease is the accumulation of abnormal formation or amounts of glycogen in the tissues, including the liver and skeletal muscle. And fortunately, it's relatively rare, but we're going to talk about these. The most common is von Gierke's, which is type 1, which is the conversion of glucose 6-phosphate to glucose. It's pretty much one of the last steps. Then there's debrancher. So when we go from glycogen, we have to use this glycogen. So we make glycogen, then we break it down so we can get it to glucose. And then liver phosphorylase. Again, I'm not going to go into all the details of these pathways. I know that biochemistry has, so if there's any discrepancies between any of these, go with biochemistry. I'm going to be talking about the clinical presentation. So type 1 glucose 6-phosphatase deficiency, or von Gierke's, usually presents about 3 to 4 months of your life. And it presents with this huge belly with a big liver, but the arms and legs are really thin. So it's failure to thrive with these cherubic cheeks and thin arms and legs. Hypoglycemia and seizures. And the reason they're hypoglycemic is they can't mobilize their glycogen for sugar when they need it. So we have hypoglycemia, lactic acidosis, elevated hyperuricemia or uric acid, hyperlipidemia, and because they're trying to get like fats, they're trying to mobilize anything that they can. And the treatment is to prevent hypoglycemia with continuous cornstarch, an easy accessible carbohydrate, and restrict lactose and fructose from the diet. And those can be, put into glycogen. So we do everything we can. The next one I want to talk about is the muscle disorders, the glycogen muscle disorders. So some affect the liver and some affect the muscle. So Pompe's disease, which is actually a lysosomal and glycogen storage, McArdle's, and phosphofructokinase deficiency. And I'm going to talk about Pompe's when we talk about muscle disorders in more detail, but I want to talk about McArdle's, which is a deficiency of the enzyme muscle phosphorylase. It's caused by, it's autosomal recessive by the PYGM gene, and the absence of this enzyme reduces ATP generation by glyconeogenesis. Symptoms usually present in the early 20s, sometime late teens, usually after exercise. So the patient will often decide, I started this new weight training thing and I was doing really great, but oh my gosh, my muscles hurt so much when I'm done. And then, my urine looks like blood. It's not blood, but it's really dark, cola colored. CPK or creatinine kinase is usually very elevated, sometimes into the thousands, and usually it shouldn't be over 100. And the diagnosis can be made by either a muscle biopsy, which we don't do too often, or looking at genes. About 100% of patients have this mutation, which is much less invasive than getting a piece of muscle, but neuro would probably disagree with me. Anyway, treatment: avoid strenuous exercise. So no more weightlifting, IV fluids with glucose during times of rhabdomyolysis. So rhabdomyolysis is when the muscles start breaking down. And CPK is inside the muscle cells. And when there's ever breakdown, it gets outside, not just muscle cells, but cells in general. So when the CK or CPK is really elevated, it means the muscle is destroying itself. Another similar disorder is phosphofructokinase deficiency, and this is the lack of the enzyme fructose-6-phosphate. It looks similar to McArdle's, but can be seen earlier, can present in childhood, can have hemolysis, which is breakdown of blood cells, really high elevated uric acid, and exercise intolerance is even worse after a carbohydrate meal, which a lot of people tell you to do before you work out, so not good. So take-home points. The age of onset of metabolic decompensation is important in determining a possible cause. If the patient has alkalosis, consider a urea cycle disorder. If the baby is acidotic, consider either where it's coming from. Is it lactic acid or organic acids? And certain smells from the baby in the urine or even, the body or the earwax can be kind of a clue. Adult onset glycogen storage disorders can present with muscle cramping and this red-colored urine. So I have a couple USMLE questions that I took from one of the books, and we're going to go over this. A 24-year-old woman with phenylketonuria has her first child. There's no family history of PKU in the baby's father's family. The baby was born with microcephaly. The level of phenylalanine at birth is elevated. What is the most likely cause of the baby's microcephaly? And the reason I put this in is I wanted to talk about maternal PKU. Elevated phenylalanine in the mother is actually teratogenic. So the baby has PKU. Well, it could, but actually babies with PKU don't have any birth defects. They're not microcephalic because their mother was filtering it. So I suppose it's possible. The baby is a carrier for a mutant phenylalanine hydroxylase. Well, that's true, but that's not why the kid's microcephalic. And again, I didn't write this question. I took this out of a board thing. The father has PKU. Well, there's no reason to believe this. And phenylalanine was not adequately restricted from the mother during the pregnancy. So the correct answer, if I was better at moving this thing over, is actually D. And again, I did not write this question, but phenylketonuria or PKU is teratogenic to the baby. The maternal phenylalanine is teratogenic to the baby. So this woman that has PKU, no family history of PKU in the father's family, the baby is born with microcephaly. Again, babies with PKU are born completely normal and healthy. It's after, it's by not having restriction of phenylalanine that's destroying that brain. So you would not expect the baby at birth to be microcephalic. So again, if you guys were taking an exam, you would argue about a lot of these things, but I swear to God, I didn't write this question. I'm just going over board questions. The next question is, again, I took out of a book. A 9-year-old female has mental retardation. She was healthy at birth. She presented in the first week of life with vomiting, lethargy, and seizures. An amino acid screen identified elevation of leucine, isoleucine, and valine. The baby was placed on a special diet. She has had no medical complications since that time. Which of the following enzymes is most likely deficient? So they're just telling you they have this delayed 9-year-old, and she was healthy at birth, but she had these symptoms, and she had elevation of leucine, isoleucine, and valine, and she was placed on a special diet, and she's been fine since then. What does she have? So this is maple syrup urine disease, and so it's the branched chain keto acid. So again, both of these were taken from board questions, board-like questions, and these are the kind of metabolic questions that they ask. The reason I'm going through all this stuff is a lot of these clinical presentations will help you get to the right answer and also reassure you that you're at the right answer. So I know biochemistry has a lot of stuff they're going to expect you to know. And that's great. But, you know, if you saw this and you said, oh, she's 9, she had this leucine, isoleucine, and valine, I should think this is maple syrup urine disease. What they're asking is what the enzyme is. This would be propionic acidemia. This is urea cycle, methylmalonic. This has to do with cystathionine, the homocystinuria. But what they gave you the answers is the amino acid screen, leucine, isoleucine, and valine. And again, we put the babies on a special low protein diet that have low amounts of leucine, isoleucine, and valine. And this is the enzyme. So I just wanted to kind of show you the kind of questions that they ask on STEP with regards to metabolic disorders. And that concludes. I also want to say I understand this is overwhelming, really tough. And that's why I tried to put this together as, again, kind of dovetail with the metabolic stuff. For this is what people look like. They like to ask questions about maternal PKU, that phenylalanine, really high phenylalanine is a teratogen. That, you know, babies are actually born normal when they're born with PKU, but if they don't stay very strictly to their diet, they can have issues. Anyway, that concludes this module.